Yeah, actually, my parents just left for Florida on a short vacation.
Ooh.
So we're here at home during midterm season while they're going to go to the beach. So
So they're
that's always
living the
fun.
high life while you're living the student life.
Yeah. So they're going to be sending me pictures of them relaxing and of course.
You live vicariously or you realize what you're missing.
Mhm. Mhm. All right, we can give it just one more minute and then we'll get started.
And so before we get started, do you want to tell me just a little bit about what AMSA is as well? And like, is this all kind of 4 years of students? Do we have postbacks as well?
Yeah, so we will be discussing a little bit more about what our club is during the meeting, but just as a short little highlight, our local chapter is just for the pre-med sector. So for UTD, it's all 4 years of undergrad. Anyone can get involved at the local level. We're affiliated with the national level though, and at that point is where you get the medical students, the residents, and other pre-meds throughout the nation. So it's pretty cool.
Excellent.
Alrighty. So thank you everyone for joining us for our second general meeting of the UTD chapter of AMSA. So glad you guys can make it this evening with us. And we have a great speaker with us tonight, Dr. Voit, and she will be having a presentation on some really cool topics. So just to get started, our officer board for the 2020-21 school year, once again, I'm Stephanie, your co-president. Sneha will be joining us a little bit later, but she is also a co-president. We work together to make everything happen. Shruti, if you could just introduce yourself briefly.
Hi, I'm Shruti. I am the treasurer of our club. I'm currently a senior neuroscience major.
Hey everyone, I'm Ariba. I'm also a neuroscience major and I'm a sophomore.
Oh, sorry about that. So Lickett is not here today. He has another conflict. He is our volunteer outreach coordinator. Avirut is also not here, but he is our clinical outreach coordinator.
Hey guys, I'm Lane. I'm a sophomore biology major, and I'm the secretary of AMSA.
And we have two past officers, Pooja and Alex. They kind of just help us out with the officer role and advise us. Alrighty, so you might be wondering, what is AMSA? What stands us apart from other pre-med clubs is that we don't have an hour requirement, no GPA requirement, or any dues. So you're here, you're basically an AMSA member. The purpose of this club is to really give you guys some really good resources as you go on through your pre-health journey, whether that's volunteer opportunities, shadowing, which can't really happen this semester, but hopefully in the future we can have it work, and some other topics such as medical ethics discussions, in the news discussions, which we have a section on every meeting, and a new thing we're doing this semester, which is advocacy. So we're highlighting the advocacy initiatives at the national level. If you are interested in joining at the national level, there is a fee you have to pay if you want to be a national member. Of course, at the local level, you're fine. You don't have to pay anything. You're already a member. But this is just if you want all of the resources that the national programming provides. We also give you guys some access to exclusive resources for MCAT prep and other goodies.
Yeah, so as Stephanie was saying earlier, you don't have to pay a membership fee or have any hour requirements to join our local chapter, but you do have to pay a membership fee for the national chapter. Paying for that membership fee or paying that fee for the national organization opens up more opportunities, however. So as she was saying, we've got a bunch of different, well, I say we, they've got a bunch of different programs that you can join up with. They've got opportunities for education, leadership programs, discounts on test prep materials. I know they do a program with Kaplan. that gets discounts on MCAT prep materials. They also have a class called the Pre-Med Scholars Program, which is basically just a way to introduce you to other pre-meds across the country. I think it's free if you're a national member, and then there's a fee if you're not a national member. But at that point, it'd be easier to just join the national membership and take the class for free. Can we go to the next slide? Oh.
Yeah, of course. Just one last thing about just becoming a national member of AMSA. What sets us apart is that AMSA is not just an undergrad opportunity. This will be taken along with you throughout your medical school education and throughout residency. So as you continue through, if you become a national member, they will continue to support you as you go through your career path. So it's a pretty cool opportunity if you want to get involved.
Mm-hmm. Speaking on our advocacy initiatives, so this week is National Primary Care Week with the national organization. So primary care focuses more on they're the first point of contact for patients. So this is your family medical doctor, your pediatrician, your geriatrician, just the people you go to for before you go to a specialist. So these type of doctors would take in the scope of your symptoms, and they'd refer you to a specialist if you needed it. They also focus a lot on preventative medicine. So telling people instead of how to solve issues that they're currently having, how to prevent issues in the future. So the national organization has been doing a lot of meetings and things this week regarding National Primary Care Week. I think today's focus is on women's health, and tomorrow's focus is on telemedicine. If you want to check out any of their resources on these, then you can go look at the Facebook, Twitter, or Instagram at AMSA National, and you can find all of the resources that you want.
So if you have been a member of AMSA, you might have known about this initiative that we usually do in the past called Blossom Parties, where we partner up with Brooks Blossoming Hope, in which we create flower headbands for pediatric oncology patients and then donate them. Of course, we can't quite do that this semester. Just be aware that in the future, once we're able to do in-person meetings, that this could be a volunteer opportunity to get involved with.
Okay, so we have decided to partner with the Brain Exercise Initiative. So they focus on seniors who are in hospice centers, and basically we want to engage with them. And so the volunteering opportunity we have now is that you'll kind of submit a video that engages with the seniors. You'll get volunteer hours for that, and so more information is on the link and everything. I want to stress that the people who do this opportunity, you'll be first in line for whenever we get other opportunities like shadowing or I don't know, other things. You'll be first in line to receive those opportunities. So make sure you check this out. If you have any questions, you can email Lickit, and these slides will be sent out afterwards, so you'll get the link and everything. So yeah. And then yeah, these are a bunch of virtual conferences that are lined up in the month of October. Again, we'll send out these slides, and you'll have the link after the meeting. So yeah.
Shruti, your mic's muted.
My bad. So this is a special week for science. We get to learn about people who are doing amazing things in the fields of medicine, physics, chemistry. And so we thought it would be interesting to shed some light on the Nobel Prize for medicine winners of this year. Doctors Harvey Alter, Michael Houghton, and Doctors Charles M. Rice for their discovery of the hepatitis C virus. So as most of us know, hepatitis is a disease that causes liver damage. B and C tend to be different from A in that they tend to spread via blood and silently affect patients. And so we see their deadly effects, including cancer, a while after the patient's been infected. And so back in the 1960s, a virus that caused bloodborne hepatitis was discovered, and that came to be known as the hepatitis B virus. And the discovery of this virus led to the development of diagnostic tests and effective vaccines that could prevent the spread of this disease. That being said, they found that there was still many transfusion-related hepatitis cases. And so they knew for a fact that these hepatitis cases were not attributed to either A or B. And so that's where the research of these three scientists comes into play. So there were a bunch of studies done on infected chimpanzees, and it was determined that this unknown disease was being caused by a virus. And so the patient sera was used to identify clonal viral DNA fragments that were encoding viral proteins, which ultimately helped identify the virus. And this virus was named hepatitis C. Because of the work of these three scientists, the region responsible for the viral replication was also identified. So because of the research done in understanding hepatitis C, there are now highly sensitive blood tests that are available and have prevented post-transfusion hepatitis in a bunch of places across the world. And there's also a lot of work being done in creating treatments and drugs that help treat hepatitis C. Yeah. So we often do an ethical question each meeting. And so our question for today's meeting is the following. A 55-year-old man has a 3-month history of chest pain and fainting spells. You feel his symptoms merit cardiac catheterization. You explain the risks and potential benefits to him and include your assessment of his likely prognosis without the intervention. He is able to demonstrate that he understands all of this but refuses the intervention. So our questions are you obligated to accept his decision? Should you try to push him to take the treatment? Do you have a responsibility to understand why he's refusing the treatment? And we'd like to hear your opinions. If your mics aren't working, feel free to type in your responses in the chat. We'll go ahead and read them out loud.
And I just want to say, this is a great scenario. This is a great question.
Shruti, I want to hear your opinion about how you would go about responding to these questions.
So in this case, I feel like as a doctor, your word ultimately isn't more important than the patient's. And so in this kind of scenario, we know that the patient is, fully aware of what's going on. And you've done your duty in explaining to the patient, what's happening to him. And so since your patient is competent to make the decision, I believe that as a physician, you have a responsibility to, accept his decision. That being said, I feel like you just shouldn't stop there. You should try to understand why he's refusing the treatment, maybe question him a bit. And if there are reasons why he's refusing the treatment, you should try to understand those and try to discuss with him why you think maybe treatment is better. But at the end of the day, it's his call to make.
That's a very valid viewpoint. Go ahead, Lane.
I agree with Shruti here. I feel like bodily autonomy is more important than whatever we would be trying to give to him or to the person as doctors. So like if he says no, then we've done everything that we could, and he's just not accepting it. I also agree that we do have a responsibility to figure out why he's refusing the treatment, because if there's a specific reason, then maybe we could think to the future to try and figure out how we could, or what we could do to stop that reason from intervening in this man's life.
Absolutely, I agree with you.
Are there any other thoughts about this?
Hi, I just wanted to say that I'm in agreement with Shruti, like, especially with just the whole case about patients' rights and all that. We're not really, I don't think as a doctor you should pressure a patient to accept some sort of operation or medication or anything of the like. Your job really is just to help them understand what a condition or certain disease is, and what the potential sort of solutions to fixing that would be. Now it's up to them whether or not they actually want to undergo with that. But I think, as Shruti said, we should at least try and understand if there's some sort of hesitation or doubts about some sort of procedure or anything like that. And we can work with the patient to potentially sort of clear up any of those doubts, so that we go in there with like the utmost amount of clarity, or a sort of clear conscience, if you like. So yeah.
Thank you for your response. It seems like there are some responses that are showing up in the chat, so I think I'll just go ahead and read them. So Avanish says, I think in the end, it is the doctor's responsibility to provide all the possible treatment options, and for the patient to choose their own path of treatment or not. I also wonder if many of the times patients refuse care because of cost. And that's an interesting point. Absolutely, I agree with that. Sakshi also says, I also think you should help them explore alternate solutions and treatments that may not be as effective, but may be helpful. And once again, I agree with what you're saying. Absolutely.
Those are both wonderful thoughts. Actually, the comment about alternative treatments, part of the consent process. So if I were to consent someone for a blood transfusion, it includes alternative treatments and the advantages and limitations of those. So you guys all hit it right on the head with the key points.
Awesome. Well, thank you so much, everyone. This is a really good practice to get ready for medical school interviews, especially with MMIs. They will be hitting you hard with some of these ethical dilemmas and situations, because you will be seeing it throughout your medical career. So they want to test you early on to make sure that you know how to respond. And while there might not necessarily be a right or wrong answer for some questions, it's important to have a good response ready when they do test you on this. So thank you everyone for your participation. This was really fun. All right, so it is my honor now to introduce Dr. Jessie Voit. She is a fellow Comet, so she is a UTD alum coming back to bestow some wisdom onto us pre-health students. She is an assistant professor in the Department of Internal Medicine at UT Southwestern, and she specializes in geriatric medicine. So she also works with UTD students in a volunteer program called Comet's Help. And I know her for a couple years now because I'm also part of that program. So it's been a really great opportunity to help improve the care of hospitalized geriatric patients. The purpose of the program itself is to provide companionship to elderly patients hospitalized that might be at risk for developing delirium or depression or loneliness as they're undergoing treatments for many days in the hospital. And especially for those that don't get many family visitors, it's so important to get that social connection. Especially during the COVID-19 pandemic, with a lot of geriatric patients having to socially isolate, this is more important now than ever. So it's a really great initiative that she has pioneered, basically, and is coming up on its third year, I believe. Mm-hmm. I think it's been 3 years already. It's been so long. So it's been a really great experience to help bridge a partnership between UT Dallas and UT Southwestern. So she's a fantastic lecturer, and I'm really excited to have her here. We're very honored to have her talk to us today.
Great. Thank you so much, Stephanie. And I'm going to see, do I have access to share? Looks like I do. Okay, 1 second. Okay. All right, here we go. And okay. We went too far. It's going to be a lot of pictures. All right. Are you guys able to see my screen?
Yes.
Yes.
Great. Thank you for having me. And so this is an informal talk. The first part is I'm going to talk just a little bit about my journey the past decade and a half. And then the second half, I'm going to talk specifically about what I do at UT Southwestern, what a geriatrician does, and a little bit about what that looks like during the COVID pandemic. This is meant to be informal and interactive, so please feel free to put something in the chat if you have a question. Stephanie, maybe you can man the chat and interrupt me if questions come up, and we can take this any direction. But thank you for having me, and thank you, Stephanie, for inviting me. There we go. So my background, so I went to UT Dallas. I was there from 2005 to 2009. And this is just a little picture collage of some of my time there, and it really brought me back. Some of the big things, when I came to UTD, I was initially a math major. I did some pre-health classes, but I didn't know what I wanted to do with my life. I think there was a good year that I thought I was going to be a statistician. I played college volleyball. So the top picture is my two roommates, and they have a sign asking, "Who's your daddy cheering for?" Because my sister was on the opponent volleyball team. And so really those first years were spent studying abroad and traveling and playing intramural sports. I did some teaching, some supplemental instructor. I was a TA for a class. I worked in a lab. So kind of all this hodgepodge of different opportunities. And it was the end of my sophomore year when I realized, even though I was good at math, I didn't get quite as excited about it as I used to. And I got a lot more excited about the biology and the biochemistry, even though I wasn't quite as good at it. And even though my grades weren't quite as high in those were the things I was more excited about studying and figuring out more and applying it. So about halfway through my college, I decided to take a turn, and I went pre-med. I totally bombed my first practice MCAT, completely bombed it, was not good. I remember my dad telling me that I might have to rethink my career if my MCAT, yes, he tells it as it is, if my MCAT didn't pick up. But I did a Princeton review course, and I studied and fortunately was able to turn the MCAT around. And then the last thing with this photo before I go on, the top right photo, so that's us. We won the Oozball championship my junior year. Do you guys still do Oozball in non-COVID years? So we were champions one year. It stormed, it started thundering, but we finished in time to win the trophy. And the bottom left is my now husband. So I met him and started dating him my freshman year. So that's my UTD experience. I then went to UT Southwestern, and I graduated Southwestern in 2013. And this top photo, the middle photo with the three of us in white coats, so we were all comets. So we all went to UT Dallas together, and that was us at our white coat ceremony, getting our white coat. And we actually had the white coat ceremony for the first year medical students yesterday and today. It didn't have the same pomp and circumstance because of COVID, but I got to hood my 6 first year medical students with their coats. In addition to studying a lot in med school, I was also an anatomy TA. So that's the top right corner. So for the physical therapy students and the physician assistant students, I got to teach one of the anatomy sections. And then I continued to do intramurals. So that's us winning the softball tournament. It sounds a lot more impressive than it was because I think there were 4 teams in the intramurals for UT Southwestern. But we were number 1 of those 4 teams. After medical school, I did my residency. So for those of you who aren't as familiar, after med school, you get your MD or your DO if you're in osteopathic medicine, and then you do a residency. And residency can be anywhere from 3 to 7 years, depending on your specialty. So internal medicine and pediatrics, these are 3-year programs. The first year is your intern year. OB-GYN is a 4-year program. Surgery is anywhere from 5 to 7. So it's a process. And so in residency, in addition to working a lot and seeing a lot of patients, we did intramural softball. We were not first. I think we were last in the league, but we had fun. And that is me actually hitting the ball. I did get a hit on that one. And we also played intramural volleyball or community league volleyball. That is the one game we won all season, so we had to take a photo. And then my last year in Michigan, I did an extra year of a chief resident year. So that's for internal medicine chief residency. You have a couple of people who are selected to serve as a leadership role. We kind of serve as a liaison between the residents and the administration, a teaching role. We give a lot of lectures and conferences. And then the bottom right is you get very glorious 2 weeks of vacations during residency. So we went to Glacier National Park, my husband and I did. Then I came back to Southwestern in 2017. I did 1 year as a fellow in geriatrics, and then I was finally done, and I joined the faculty in 2018. And so this is me getting my very last diploma from my chief, and my mom was at the ceremony. And then in fellowship, I had a girl named Emma, and so she has been to 2 geriatric conferences. Her first, bottom right, was her first conference. She was 5 weeks old. And then she went again last year, and her little sister is in my belly because I'm pregnant at that conference. But she missed this year because of COVID. We did not have a conference this year. And then this is her on my first day as an attending physician, the far left. So that was my first day having a real job in 2018. And then one of the other things, being at Southwestern, I'm also an academic. So we give lectures to medical students. And then we're also trying to make changes in medicine. So my colleague and I, so I'm the third from the left, and my colleague, the second from the left, we were one of the project finalists for an innovation Shark Tank. So we're working on improving the transition of cares in geriatrics. So that's a photo of us winning our medal with the Shark Tank. So that is a brief spiel on my path from being where you guys are in UTD pre-med honor pre-med society, and then finally kind of being done with the journey and now just starting the career. I kind of put the photo collage together, one, to make it maybe seem a little more real. I think it's always hard for me when I looked at my faculty advisors and my attendings. They don't seem like real people with lives and stories. They just seem like they know where they are and they know what they're doing and they know how to do a physical exam and how to get to a diagnosis and how to have these really hard conversations. And at the time, this is what I felt like everything was. It was all kind of like a hodgepodge scattered. Am I a math major? Am I a double major? Am I biology? Am I pre-med? Do I do volleyball? Am I coaching? It's kind of all over the place. Do any of you guys kind of feel like your life is a squiggle right now? And it very much felt that way. And when you look back at it, it kind of still looks that way. But 15 years later, when I'm now looking back at my college career, my medical school, my residency, I do find that there's more of this common thread. So when I look back at UTD, even honestly going back to middle school, but for me, when I take a step back and look at me, what makes me excited and what do I find myself drawn to in terms of activities, for me, it was teaching. So from middle school on, I was always tutoring. I was tutoring friends. I was tutoring underclassmen. I was tutoring high schoolers when I was at college. Like I had mentioned, I became a supplemental instructor for calculus. I was a first-year leader. Do you guys still have first-year leader in, what is it, Ret 1101? Is that still a thing? Yeah, is that maybe not? Okay. So I was a first-year leader. I was then a TA for a freshman class. And again, anatomy TA, I was a peer mentor and chief resident. So I realized when I was trying to think about what my career would look like, do I want to do private practice? Do I want to do academic medicine? I just realized I love teaching and I really wanted to incorporate that into it. The other common thread is for me was sports. I really enjoyed intramurals. I liked cheering on Michigan football. And so that's kind of remained my outlet and my stress relief and my helping fill the bucket when I feel like my bucket is getting a little low from a happiness and energy and joy perspective. I try to remember that common thread is exercise and sports in that environment. So I guess I encourage you, even when things seem chaotic, write down what you enjoy, write down what you're good at, and see if there are themes, and then how do you make that theme into your big picture. So my specific role, as I mentioned, I'm a clinician educator. So there are all sorts of different types of doctors. My brother-in-law he is an MD PhD. So he is a clinician researcher. He may even be a researcher clinician. I'm not sure whether it's like a big researcher or a big clinician. But his emphasis is in doing bench work and trying to cure pediatric cancers and blood diseases. He does bench work and he does medicine. He sees people in clinic once or twice a week. My role is I am more of the clinician educator. So this means I'm at an academic institution. I am doing clinical medicine. So I have my own patients where I'm their primary care provider. You talked about primary care at the beginning of the meeting. So I'm a primary care provider. I take care of patients in the hospital. So I'm definitely a clinician. But I also precept. So I have medical students who work with me in the clinical setting as I teach them about the physical exam. I teach them what do you do when someone's short of breath? How do you do the cardiac exam? I have residents, so they're already MDs, but they're in the training portion for internal medicine. I also sometimes precept psychiatry residents. And then I have fellows as well, so people who are specifically doing geriatric medicine. I also give lectures. So I give lectures at UTD to medical students, to the residency department, and then beyond as well. So I try to reach out to UT Dallas. I have obviously a very strong connection to UTD, and I want to see you guys thrive. So giving lectures at the university, at other hospitals. In a couple months, I'm going to give grand rounds at the Presbyterian Hospital. I've given lectures to nursing homes, to social workers and nursing organizations, to the Dallas Gerontological Society. So trying to educate not just medical students, but also the community. You mentioned too in the earlier meeting about advocacy. Physicians can play a huge role in advocacy, whether it be for, we're in a pandemic, so advocacy in terms of how to manage big global health issues. One of my best friends is a pediatric neurologist who focuses too in neurodevelopment. So she's a very strong advocate for just getting more government funding and awareness for neurological diseases that can affect children. And then also part of the role as a clinician educator is trying to make change in the field of medicine. So trying to get those publications and to do research, whether it's bench work or whether it's more clinical research, and trying to do projects, quality improvement projects to make things better. So I had shown you the picture of the innovation tank. So my colleague and I were working on how can we improve the transition of care when someone is hospitalized and is discharged home. How can we make sure things don't slip through the cracks? How can we make sure medication errors don't happen? How can we make sure things like oxygen tanks and physical therapy and all of those things are ordered appropriately and the order isn't missed? So that's one of the projects we're working on to improve those transitions of care for our older adults. So that's kind of my role as a clinician educator. Other people are just clinicians. So I took my daughter to the pediatrician today, and her pediatrician is a full-time clinician. She is 100% taking care of kids. So there are different roles people can fill. Some people too can maybe be more of take more of an administration role, being maybe the CMO of a hospital. There are also non-clinical roles doctors sometimes fill in terms of maybe being the chief medical officer for for an organization that's doing some sort of healthcare product. Then my other role, so I'm a clinician educator, but then I'm a geriatrician. So as mentioned, I am board certified in internal medicine and in geriatrics. So I've taken 2 separate boards. What it means to be a geriatrician is I am specialized in taking care of adults 65 years of age and older. That term older adult, it's kind of always a moving target. What does it mean? What does it mean to be an older adult? 65 tends to be the general age cutoff we use, but age really is just a number. I have some 70-year-olds who are healthier than many 30-year-olds. I have some 55-year-olds who are sicker than many 80-year-olds. So, the 65 and above is kind of this arbitrary number, but it also really goes to the overall complexity of the patient. So for the most part, I'm taking care of older adults, but they also tend to be older adults who are medically complex, whether that's having underlying cognitive problems, multiple medical conditions, or specific medical conditions that often happen in the elderly, like Parkinson's disease. And geriatrics, it can serve a lot of different roles. Me personally, I practice in the outpatient setting. So I have my own primary care panel. I have patients who I'm their primary care physician. I also do inpatient work 6 weeks out of the year. I rotate on the inpatient service with the residents and the medical students, and I'm on the teaching service taking care of patients who are hospitalized. And then I also do 6 to 8 weeks on the consult service. And we'll talk about what that means in just one second. Other geriatricians, though, some might work in a nursing home or assisted living facility. We have a very robust house call program. So at Southwestern, if you are within 10-mile radius of UT Southwestern, and you can qualify for the house call program, and the physician comes to you. And these are people who are then homebound and typically more sick and frail. So there are lots of different kind of roles that a geriatrician can fill. Does anyone have any questions kind of up until this point, either on the 15 years it took me to get right here, right now, or about the training process or what it means to be a geriatrician?
How did you get into geriatrics?
Ooh, that's a great question. Because often geriatrics, it tends to be one of those, you love it or you hate it. Some people, they say, oh no, it's a 90-year-old with 30 medications and 20 problems. I always got excited with that. For me specifically, so at UT Southwestern, we get sorted into colleges, and it's kind of like Harry Potter houses, right? You have the Hufflepuff and the Slytherin. You have your college. And with each college, you're assigned a mentor. And so that's a group, you're put in a group of 6 students, and that's where you learn how to do the physical exam with your college mentor. And my college mentor was a geriatrician. And so she ended up being my fellowship director, actually. But so in med school, she just kind of showed me her love of geriatrics. And I got to see some geriatric patients. Because she was my mentor, we went to the geriatric interest group sessions, because we wanted to make her happy. And that kind of that opened the door. And then when I was in residency, I very vividly remember talking to one patient about how it was time for her to stop driving because it wasn't safe, and a different patient who'd been having falls. And I realized I got excessively excited talking about some of these things. And so it was a very slow transition where I said, I want to be a primary care physician to I want to be a primary care physician, and maybe I'd consider geriatrics, to slowly that maybe became a I'm applying to be a geriatrician. But I really think it started with my mentor, who's now my colleague. So yeah, it's funny. A lot of my patients, when they see me, they are like, huh, you don't look old enough to be a geriatrician. It's like, well, I'm not the geriatric, you're the geriatric patient. I'm the doctor. But yeah, so that's kind of how I got into geriatrics. I think there's definitely a certain type of personality that tends to go into geriatrics. We tend to have a little more patience, and one of the luxuries, people often see geriatricians because we're given more time per patient, because these patients are very complex, often have the cognitive impairment, which makes things more difficult. And the hope from a hospital perspective, from a university, is, well, let's give you more time. And hopefully by having that more time, you're able to do more to prevent them from getting sick and going to the hospital. So even though I don't earn as much money in one clinic day, I save the hospital money because hopefully she doesn't have to be readmitted because she's in a heart failure exacerbation. So like from a system perspective, we are very advantageous for the hospital. But if you look at it as a pure billing of how many patients did you see today, if I take twice as long with a patient, I'm going to see half as many patients, which is a systems, as a system, I think we need to figure out how can we, I don't want to say reimburse, but how can we figure out how to make it sustainable so that we can do the quality of care that you need for each type of patient. But looking at my colleagues, we tend to be similarly enthusiastic about preventing problems, so preventing falls, preventing hospitalizations, getting rid of unnecessary medications, and then just also listening. One of the big things with geriatrics is we focus on function. So yes, I care about your lungs, I care about your heart, but I really care about how do these organ systems affect what you're able to do. So if you're having trouble breathing, I really care if you are unable to do your laundry, or you're unable to do your cooking, or you're now not able to walk across the street and play with your grandchild. So we think about it not just in terms of pure numbers, but also how it's impacting the function and the ability to live independently, or the ability to do things that you enjoy.
I had another question.
Yeah.
About your journey. So, I mean, first of all, you started out as a math major, so I guess like becoming a doctor wasn't like the initial thing in your head coming into college, but once you decided, and went through like the MCAT process and it's continued onwards, were there ever times that you felt really discouraged, and like how did you get yourself to keep going?
Yeah. So that's a good question. I think there are two different things in there, and I'm not sure, it might be both. So one, it's when things don't go well. Sometimes there's the confidence. Where do you have the confidence to know that you still can do this? And one thing I'll say is medicine is not for everyone. So the thing I urge you, I'm kind of in reverse, but don't feel obligated to do something just because you always said you would, right? I entered as a math major. I entered as a statistician. I didn't end up that way. It is okay to change your major. So don't feel obligated to continue something just because you thought you would. I think one, and my first biology test did not go well. My first MCAT, I mentioned my practice test was atrocious. I think one is always then stepping back and saying, like, what went wrong? For my first biology test, I talked to the professor, I looked at it, and I realized I was studying for biology the way you study for math test, and that doesn't fly, because biology is a lot of memorization. You can't like figure your way out to a definition the way if I had the theorems, I could figure out a math problem. So I realized I had to change. So I think some of it is trying to do an objective look and talking, if you're not succeeding, talking to people of what do I need to do to change to be more successful? Is it my study habits? Is it the type of studying I'm doing? It's not just enough to study 12 hours if it's the wrong type of studying. And I think for confidence, the other thing is I was very fortunate in having some great friends who then became my confidence, and I was able to tell them. It wasn't like a secret. I was like, oh, I did not do well on my practice test. And that helped make it feel less shameful, so it didn't beat me down as much. I think one thing is when you hold your failures in, they become that much more shameful. And everyone has points of insecurity, and everyone has things they don't do well. And so I think when you're able to talk about some of those failures or insecurities with people, you can learn from each other. And it's not that elephant in the room that is almost paralyzing. I guess on that note, in medical school, I remember we do standardized patients. And so you're videoed and you do your patient encounter, and then you get your like score sheet and you watch the video, and it's horrible. And I remember one of them, and the patient was just like, you were very stiff and robotic. It was uncomfortable. And I was devastated, because I'm like, well, how am I supposed to be a compassionate doctor if I'm stiff, robotic, and like, I don't know. I don't remember all the other things, but I remember being devastated. And I finally did tell someone who we were sort of close, not good friends yet, but we ended up being best friends. And for me, one, letting it out so it's not this elephant in the room was helpful. And then like hearing from her saying like, oh, mine was awkward too, but you'll be great. I'm not worried. That helped get some of that fear away from me. And that's also a personality thing. Everyone might be a little different. What I need in order to cope with not doing well might be different than what you need or what someone else needs. And then I forgot the second half of the question. Did that answer?
I think you kind of answered it, just like how do you get past like, those feelings of kind of low confidence and low self-esteem. But yeah, that covers it.
And then the other thing I'd say is, so one, imposter syndrome is very real and very prevalent. I'm actually going to talk about imposter syndrome at a different organization meeting in like 2 weeks. But I think sometimes recognizing that some of this is in your head and that lots of other people are feeling it too helps. And then the other thing I think is making sure you have your outlets. For me, I enjoy, sports. I enjoy cooking and baking. So sometimes I need to bake and then feed it to people or eat it myself. But sometimes then also like stepping back. So finding out what is your stress relief? Is it yoga? Is it listening to music? But I think having those outlets are very important. It's something that's often neglected in college and in med school, because you think you just have to keep pushing through. But if you're not able to find those outlets, you can't push through as much. And I think sometimes not being scared to reevaluate. Some people say, like, I want to be a neurosurgeon, and the board scores might not be good enough. And that's okay. It's okay to reevaluate. I had a great friend who at first thought she wanted to do ophthalmology and her board scores weren't very good. And then she decided to switch to OB-GYN, and she's a wonderful OB-GYN, and it really fits her personality. So I think don't see that as a failure, changing.
We do have a question in the chat. What's the toughest part about specializing or practicing geriatric medicine?
Ooh, that's interesting. I was actually talking to my mom about this today. I think one of the hard things is some of the problems I see don't necessarily have good solutions. I saw a patient this week who has worsening cognitive problems, exacerbated by drinking, but underlying cognitive problems. And so the hard thing is, how do we keep her safe? She wants to live by herself. She wants to drive. I made it very clear driving is not safe right now. We need a formal exam before driving. But sometimes some family members come together and they're like, okay, we're going to hire an aide. We're going to, make sure we check on her. I'm going to take care of her medicines. And some family members are able to do that. And that's when things move very smoothly. But it's very hard sometimes when people come and they just say, Mom has dementia. Make sure you take care of her. And it's like, I can't give her meds every day. I can't, we need as a team to find a solution, but a lot of that often falls on family and Medicare. So for insurance, Medicaid and Medicare are the two big government insurances. Medicaid deals with poverty. There are some other, asterisks, but Medicaid is more income based. Medicare is the 65 and above, and then some other asterisks, but big picture. So Medicare is what I often deal with. Medicare does not pay for nursing homes. It does not pay for someone coming to the home to help you with your laundry and to help you with your medications. That comes all out of pocket for patients unless they have some other form of insurance. And I think one of the hard things for me is when I'm able to identify the problems and the solutions are harder, or they don't necessarily have the family support or the financial means for the best solution for the patient. And that's really sad. And I think that's then where advocacy comes into play. Like as a system, how can we help improve that to protect our older people? That's probably one of the most things. And then the other thing has nothing to do with being a geriatrician, but medicine. There's a lot of paperwork. So for me, I like talking to people. I like taking care of patients. The paperwork can be daunting. And for me, probably that's the part of my job that makes me the grumpiest is the non-medicine stuff. Did that answer the question? I realize I go off on tangents, so call me out on it. Bring me back. Okay.
I think you answered it pretty fully.
Wonderful. On the flip side, it's also, I guess actually this is a great part going back to your point of the other thing is there are some really hard times in medical school, in residency, in faculty. There are some really hard times. You see sadness, you see death, you see trauma. It can be very hard. You sometimes maybe don't make the right decision, or you make an error, and it can be very hard. And the thing I always really urge people is to remember the highs, because you will have lows. And so really remember the highs. Remember when the patient gives you a hug, or when the patient tells you you saved them, or you changed their life, or when they tell you like with such pride, like, this is Dr. Voit. Remember those highs, because for me, those highs help get through the lows. And it's very easy to focus on that, what you did wrong, or the patient who was unhappy with you, or the patient who had the unrealistic expectations. But don't forget about all those other patients that you've made such a big difference to. So that's the other thing for me that gets me through the bad days, are remembering those good days. All right, so this is kind of a taste. So oh, hold on. Okay. This is just, I pulled a screenshot from my calendar for this week. So Stephanie had kind of asked what a typical day looks like for me, or a typical week. And so right now this week I'm only in clinic. I'm not in the hospital. I'm not on consults. So this is just a screenshot of my Outlook calendar. And so you can see I have clinic. So I'm in clinic. I have 6 half days. So, Monday, Wednesday, I'm in clinic all day, and Tuesday and Friday, I have a half day. And then I also have meetings. So I had a lecture I had to go to, and just meetings scattered. Some student advising. So I was kind of mentoring 2 students who are going to give a talk on Friday. I had some events. So we had our white coat ceremony, which was unfortunately virtual, but still exciting. Classes and lectures that I help teach. I have you guys on here today. And then also life. I had to take my kids to the pediatrician this morning. So it's a lot to balance. So organization is key. I was not the most organized college student. I urge you to try to work on it now so that you have your system by the time later on. But so yeah. And then this is a typical clinic day. So this was my clinic day last week. So this is legitimate. I didn't modify anything other than I might have condensed. We might have talked about more. But so I was in person. So I saw these people in person. And my first one was a 72-year-old, and she is like rock star healthy. She's on 3 medicines. And she was just coming in to follow up, no reason. And her heart rate was going 140. Does anyone know what a normal heart rate is? Do we have any like EMS people?
Is it in like the 70s to 90s?
Yeah, perfect. So 60s to 100 is technically normal. So yeah, 70s to 90s. And so she was 140, which is fast, like very fast. For adults. Kids do that. This is why pediatrics scares me. I don't understand kids anymore. But that was fast. But she was asymptomatic. When I asked her, she's like, maybe. I'm not sure if I feel anything. So my first patient of the day, I had to figure out what her arrhythmia was and how to manage it. And 120/90, 120 is a great systolic blood pressure. Hers was normal, actually, is a big thing for that. So we had to figure out how to manage it. And also, could I do it as an outpatient, or do I need to send her to the emergency room? So that was my first one of the day. My next one was back-to-back husband and wife. And we talked about obesity and diabetes and blood pressure, and then also just how COVID has affected her anxiety, because she has some underlying anxiety. My next one was a 92-year-old male. I love when you get the 90-year-olds, and he was falling. So he was having some balance concerns and falling, and then a little bit of prostate issues here and there. I then had a 95-year-old who was quite short of breath and fatigued. An 84-year-old who has metastatic cancer, was on hospice, then withdrew hospice because she's thinking about getting a second opinion. So we talked about what her goals of care are. We talked about her symptoms. A 79-year-old, so one of my younger patients of the day, with advanced dementia, but has zero insight into her dementia. She has no sense of her cognitive impairment. And her husband's actually thinking about moving her to a memory unit closer to home, closer to her daughter's home. A 78-year-old who has new iron deficiency anemia. So my worry is, why does she have anemia? Is she bleeding somewhere? An 89-year-old with diabetes and hypertension, but also dementia, which makes management hard. And then finally, another 89-year-old who's doing great. I wrote knee surgery. It was knee surgery. So she just had knee surgery, and she did awesome. Her pain is better. She's walking better. She's doing great. And I like this too because you can see the ages, so on the older side, but the age alone won't tell the picture, right? My 89-year-old with the knee surgery, probably she was probably the easiest one of the day, and kind of doing the healthiest of the day. My 79-year-old with the dementia was certainly the one with the biggest deficits related to her dementia. So that's my typical clinic day. A lot of both acute issues and then also the primary care. So this is how I see a geriatrician. So we do primary care, right? I'm managing the diabetes, the hypertension, the mammograms and colonoscopies, if still appropriate, the vaccinations. We're also managing geriatric syndromes. So this is when you have a combination of things that can all lead to one symptom. So we talk about falls, we talk about confusion and delirium, we talk about incontinence, so when you lose control of your bladder or your bowels. So we're focusing on those as well. We do a lot of psychiatry. One of the things I think younger people do a very good job of is getting rid of the stigma of mental illness, and psychiatry has become a much more accepted, field in our generation. I think saying I'm going to see a counselor is something that's applauded rather than shamed for the most part in our generation. A lot of the older generation, though, still holds on to a lot of stigma and does not want to see psychiatry. So some patients really don't want to see a psychologist or a psychiatrist, and I am their primary psychiatrist. And then, as we talked about earlier, just overall function. I'm trying to piece it together. How is their walking? Are they able to do, are they able to shower? Are they able to bathe? Are they able to feed themselves? Are they able to do their taxes and pay their bills? Are they being taken advantage of financially? Are they still able to drive? If not, how do we get them groceries? And at the center of all of this is the patient. So remembering it all comes down to the patient. Going back to your ethics question from earlier, the biggest thing that the prompt didn't do, and that I think you have to do, is ask the person why. Why do you not want to get the catheterization? Someone mentioned in the chat the cost, and I agree, right? If they say, I'm worried I can't afford it, well, maybe insurance pays for it 100%. That's not a big worry. It's not a problem. I've had patients say, well, I really can't be away from my wife for one day to be in the hospital. She has dementia. I'm her primary caregiver. And in that sense, sometimes saying, well, in order to take care of your wife, we need to take care of you. And that might change the conversation. Can we have a family member stay with your wife for a day? Some people, my dad went for a catheterization and he died, so I can't have it. So that might help you delve into the why. And then some patients really just don't want it. They say, I am 85. I have had a good life. My symptoms aren't bad. If this is what gets me, this is what gets me. I would rather not have a procedure. And that's fine. That's good to know. And that way you can best serve them. But I think the why is very important. Can you guys hear my baby screaming in the background? Sorry, she's fine. So that's the clinic. So on the wards is a term we often use when you're talking about being on the inpatient side. So if someone's hospitalized with a pneumonia or something, as doctors or as medical students, we often say we're on the wards, the hospital ward. So this is actually a picture from the wards. So this is Dr. Dalton. He's the director of the acute care of the elderly inpatient unit at Clements at the University Hospital. And so on the wards, just like an internal medicine ward, we take care of people with pneumonia, with GI bleeds, with heart failure, with COPD exacerbation. We often also see some of those geriatric syndromes. So you might see delirium. So that's an acute change in cognition and awareness. We sometimes deal with falls and consequences of falls, like someone who's had a hip fracture who can't walk anymore. And then failure to thrive. But failure to thrive, that's really a pediatric term. It's a term we often use when a child is not growing or gaining weight appropriately. In the elderly, I don't like when people say failure to thrive, because something is causing that failure to thrive. One of my mentors said, if ever you say a geriatric patient is having failure to thrive, that's really the physician having failure to think. You're not thinking about why they're not doing well. Is it a malignancy? Is it a hormone imbalance? Is it depression? Is it dementia? Something is driving that. But sometimes those are people we take care of as well. They're no longer able to take care of themselves at home. And so we're doing the medical workup before we get them in a safer environment. And then consults. So for those of you who haven't heard the phrase consult before, when you're in the hospital, there's a primary physician. So whether that's the internist or whether that's the surgeon or the neurologist, there's one person who's the primary team. They're the ones putting in orders. They're the ones taking care of the patient. And then they can consult other specialties if they have a question. So for instance, let's say you have a patient who had a heart attack. As the internist, you might consult cardiology to do a catheterization. So we have a geriatric consult service, and a big chunk of our patients are surgical patients. So the surgeons are either before the surgery or after the surgery call us to help with management of the medical side. So whether that's taking care of delirium or helping them with medications. And so we see a lot of patients who have spine surgery, hip and knee surgery, or cancer surgery. So for instance, if they have pancreatic cancer and they have a surgery called a Whipple, we're consulted on those patients to help the medical side. We also are sometimes consulted by both surgeons and internal medicine doctors for delirium. That's kind of our bread and butter. This is our thing that we're experts in, is taking care of confusion in the elderly, or dementia. So dementia is more of the long-term, progressive, chronic problem. As mentioned, medical management, particularly in complex patients. Sometimes these things all interact with each other, and you have to think about a couple of things at once. And then also we often help with goals of care. And when we say goals of care, that's really going down to the whole idea of what does the patient want? If a patient has a cancer diagnosis, do we want chemo? Do we want radiation? Do we want aggressive treatment? Or do we want to do a more comfort-oriented approach and maybe talk about hospice? So we can help with some of those conversations. So COVID has made things a little trickier. Obviously, the hospital stuff hasn't changed. The inpatient, we're still taking care of patients in the inpatient. We're still seeing patients on the consult service. The only thing that's changed for us is our physical location actually changed hospitals because they needed to open up more COVID beds at Clements. So the geriatric floor is now the COVID floor. So we're at a hospital across the street. Clinic has been the biggest change for me during this COVID pandemic. So we now do a lot of telehealth. And fortunately, at first they were not going to let us get paid for doing telephone visits, but now we are allowed to get paid, at least during the pandemic, for if the person doesn't have video capacity. But we do a lot of telehealth, so video and telephone visits. And it's interesting. I've learned a lot. I think there are a lot of challenges. So for me right now, I do, of my 6 clinic half days, 2 of them are in person and 4 of them are remote. And the challenges, as you can imagine, technology. So even with tech savvy people, they have pop-up blockers, or the mute is having trouble, or their Wi-Fi is really bad because they're quarantining over by the lake. And then you can imagine throwing in a 90-year-old who's not technologically savvy. So technology is hard. Hearing impairment. I have a lot of patients who are very hard of hearing. And so they can have trouble hearing on the phone or hearing on the computer. As often what's worked better is if they are able to have a child next to them. And so I kind of say it to the child, and then the child yells in their ear, and then they say it back. In clinic, in person, the hearing is a problem because we read a lot more lips than we realize. And in clinic, I'm wearing a mask and a shield. So one, it has the double penetration for them hearing me, and then they can't read my lips. So it can be challenging from a hearing perspective. Cognitive impairment, it's just very challenging to do some of these things on the computer when the patient has dementia. It's that much harder for them to use the social clues and the context clues. Obviously, a limited exam. So, if a patient's coming in with back pain, I'm not touching their back. I'm not manipulating their hips. I will often tell a spouse or a child, I will kind of do the patient on the telephone this week, so he doesn't have video. So I had him on the telephone. I wanted him to do this because this is one of the tests we do for carpal tunnel. It's do that. So I kept trying to describe, and I wasn't prayer, and then fold them like inward the exam. So hard conversations are just that much harder. I've had a couple of people transition. It stinks doing it over the computer when you talk at the same time, and when you're talking about death and dying on the computer. And it's that much harder when it's person if I know them. So in clinic and
Dr. Voit, I hate to interrupt. It seems like you're cutting in and out a little bit. I don't know if it's connection on my side or Yeah, it looks like it's breaking off a little bit for others as well.
Probably my Wi-Fi challenges of COVID. Can you hear me a little better?
You are still kind of lagging at points.
Bars. Can you hear me? What I'm gonna do is try calling in from my phone and see if it's better. 1 second.
Okay.
All right. Is that any better?
It's better in terms of the lag. There's a little bit of an echo though. If you have earbuds, that could probably help with the sound.
1 second.
I think it may be because you're logged on to two devices really close. I think it was that kind of echo that I was hearing. So
Okay. Are y'all able to hear me now?
Yes.
Okay. And Stephanie, or will someone say something? Because I can't tell if it's in my earbud or on the on my phone.
Hello.
Let's see. Are y'all able to hear me?
Yes, we can.
Fun. I am not able to hear you, Stephanie. You might have to text me if there are questions, okay? So this actually, that was not planned, obviously, but technology has made some of my telehealth very hard. And older adults aren't as great with rolling with the punches. But sometimes I have a video on the computer and then I call the patient and do the telephone because the audio isn't working. And then the final thing, I don't know if you caught it, but hard conversations can just be so hard over the telephone or over the computer. I'd much rather hold a patient's hand or be able to talk to them in person. But, so that was the negatives. I started with the negatives. There are advantages. So with telehealth, so one, it's safe in a pandemic. My patients are very high risk. I have patients who are getting chemotherapy. I have patients who are 95, 98 years old, and they're the ones that are most at risk for catching it from someone in an elevator and getting very sick. So this is helping keep things safe. The other thing is, since we have transitioned to telehealth, it means the clinic is safer for those who do come because we're able to keep the waiting rooms more empty. The elevators aren't as packed because 2/3 of our clinic is doing it remote. It's convenient. So one of the things that can be very hard in geriatric medicine is my patients might not be able to drive. So they might be reliant on their child to take a day off work and then come drive 40 minutes to pick them up and then drive 30 minutes to take them to Southwestern and then wait for the appointment and then drive them back. And you can see how a visit can be a whole day activity for a lot of my patients. And it's nice if it's really us talking about your blood sugars and your blood pressures, if I can pick up the phone and have a visit and they aren't reliant on transportation or anything like that. On that note, it's good for quick follow-up. Oftentimes I see a patient in person and then we add a medication or maybe, oh, thank you. We add a medication or we, talk about their anxiety and depression and you really want a quick follow-up 2 or 3 weeks later. It's nice to have that follow-up where you don't need an exam. It's more just talking and touching base. It's fun for me to get to see patients in their home environment. Stephanie, do you want to go to the next slide? Yeah.
it's fun for me to get to see patients in their home environment. So just this week, I was able to, I saw a patient, she was on her living room couch. She had her grandchild in her lap. Her dog was next to her. So I'm able to get a sense of them in their actual home environment. Clinic kind of feels like it's my turf, right? You're in this cold exam room. And this visit, though, I'm getting to see them in their living room with their pictures and their paintings and their family all around them. And it's a different environment. It's also really nice for me to get to see how do they function in their environment? Are they able to get up off their couch? Are they able to navigate a very crowded living room? Does it look like their living room has rugs and cords and things they might trip over? So it really gives me a different insight into how they're doing at home. So there's certainly advantages as well to getting to incorporate telehealth. And I think that was my last slide, and now I kind of wanted to open it up to questions, be it about kind of practicing medicine in 2020, practicing medicine during a pandemic, or geriatrics in general, or just about anything. Oh, and I just realized I might not have sound. Hold on. Let me see if I can fix the sound. Give me 1 second. I'm gonna try logging in on the other teams. I don't know why my team's phone sound is not working. Stephanie, can you say something just so I can see whether or not it's my AirPods or whether it's...
Yes. Can you hear me?
Okay. Okay. Hopefully the sound's a little better. Can you guys hear me okay?
Yes.
Yes, we can.
Wi-Fi is a little spotty at times. Sorry.
No worries.
And thank you for patience with the sound. Unfortunately, that happens during our telehealth visits, and it's frustrating. I think one of the chat was, do you think we might transition to more telemedicine even after the pandemic? I do. So I think this was a movement that was starting. I don't know some of the logistics or what's going on in the background. You used to need a special type of license. Thinking too, it gets tricky in terms of state lines, meaning I can practice medicine in Texas because I have a Texas medical license. What happens when my patient is in Maryland? My malpractice insurance is in Texas. I am subject to Texas tort law. So what happens if I do telehealth with someone in Maryland? In non-COVID times, you had to have a special telemedicine license, I believe, and you had to have a license in the state that the patient was in. During COVID, that's kind of on hold. We're in an exemption thing, but I think telemedicine is here to stay. And I think some of those exemptions will have to be sorted out. I don't think it will replace medicine. So kind of like my very first patient of the day, had that been a telehealth visit, I would not have known her heart was going 140. She did not have symptoms. So there are some things you need to do the exam. You need to listen. You need the exam and the in-person. But I think there are some things that are certainly better served for the patient on telehealth. It's hard right now. I have some patients who are very scared to come to clinic, and they need to come to clinic, and I just can't convince them that this problem can't be solved on the telephone. So that's a challenge I've had as well. And I think some things like pediatrics, I worry if too much is done telehealth. I want my kid examined. I want her to listen to the heart and to make sure that there's not a murmur in my 1-year-old. I want to make sure that they're growing appropriately and their weight is growing appropriately and they're developmentally okay. So I think there are some things that just can't be replaced by telehealth.
So, as a longtime teacher, what is something your students or your patients have taught you?
That's a good question. So I guess a couple different things. So one, it wasn't something so much that the patient taught me. It was something I was doing that then a patient's son highlighted it to me, and it made me realize how easy it is not to do it. So one thing that often happens in older adults, especially if they have cognitive impairment, but not necessarily, is we sometimes just defer to the child, to the person who often might make some of the healthcare decisions. And that can be very condescending. It can be discouraging. So one thing I would still always talk directly to the patient, even if they had advanced dementia, and I would kind of position my room. And I guess I had a son tell me that that night his mom told him how much it meant to her that I talked to her instead of talking over her. And for me, that's stuck home, and that's something I keep trying to teach my students because it was so important. So just remember that. Remember, even if someone has dementia, even if just keep them in the center. Other things students have taught me, I think there's so much because you incorporate it into your practice, right? I think one of the biggest things is to always be listening to other people. And how did they word that? How did they break that bad news? How did they engage with the patient? And how can I then incorporate that into my practice? How can I, does that phrase work well? I remember I was just observing a goals of care conversation, and the other doctor, it was one of my colleagues, one of my friends. She said the family had decided to withdraw care. They had decided that they were gonna, the person was on a breathing machine. They were not gonna recover. They weren't gonna come off the breathing machine, and they made the impossibly hard decision to remove the breathing tube and make their loved one comfortable. And she just told the patient that how it was such a medically appropriate and compassionate decision. And just her way of saying, like, as a doctor, that's a good doctor decision. And as a person, it's because you care about the family. I got chills when I heard her say it, and it stuck with me. So I think listening to these things that other people can say, and it might be doctors who are who are higher in their training than you. It might be students who are earlier in their training than you. It might be different professions. It might be a nurse. It might be a physical therapist. So I think kind of listening to what they say and how they say it. And then the other thing I'd say is, so a practical thing. Also, like I learn all the time from the residents who are, maybe they're more up to date with a new trial that came out, or they learned this from a psychiatry attending. So I learn all the time from my students. One of my students, one of my residents, she taught me a relaxation technique that I can give to patients when they're feeling anxious, that I kind of like it more than the relaxation technique I taught my patients. So I've started incorporating that into my practice.
Awesome. That's really cool to hear. I had one quick question before we went into the chat. So with COVID with COVID happening and college students coming back onto campus, I know there's been a lot of controversy about the dependence on COVID testing, whether that's like the drive-through ones or the saliva ones or the nasal ones. So I wanted to get your opinion on how much students should depend on those, or just anyone in general should depend on those, whether that should give them kind of like a leniency to see people and then depend on kind of like that to make sure that they don't have the virus, or also just mask usage with people that they see all the time and so on and so forth.
Yeah, that's a great question. I'm going to put an asterisk. I'm not an infectious disease person. I'm not so, this is my, I guess, opinion, so don't quote me, but this is my thought. So I think one, there's a huge need for easy access testing, but I would not have a false sense of reassurance for that. I think it's important to know because it can help with the contact tracing. It can help, right, if you are positive and you're feeling a little more short of breath, I think it's helpful to know. But I think even if your test is negative, we do know there are false negatives. And particularly when you're talking about the more rapid tests, the saliva tests, at least as of right now, there are a lot of false negatives. And so I think if you can get into a false sense of complacency and reassurance, that's how you get a major outbreak. And honestly, like looking at the Rose Garden, like they were presumably getting lots and lots of tests and not wearing masks and not socially distancing. And I think right now we need to mask and we need to social distance unless you are in your family and you're knit. When I send someone for COVID testing, I have a very low threshold to do COVID testing. But if I am concerned, I tell them, even if it's negative, I want you to stay home for 14 days. One of my patients, her husband tested positive for COVID, and I tested her and I told her, but even if you are negative, you need to stay home in quarantine for 14 days. So I think doing what you can, I think you can't shut everything down completely. That's not feasible for mental health, for personal, for everything. But I think optimizing your safety. So for us, we are going on walks with my parents, but we're keeping our distance. And if we are getting closer, we wear masks. But we're keeping it outside. My parents are, older, so high risk. And so I think at work, we always wear masks at work, always. I would never be near a colleague I take it off in my office, but if someone comes to my door, I put it on. So I think doing everything you can to encourage it as well. And then I think the other thing is realizing, for me, it's not an act of fear. I'm not wearing the mask because I'm scared of the virus. I'm wearing it because I care about other people, right? If Stephanie comes and needs to talk, I'm wearing my mask because I care about her, and I don't want to potentially expose you if I don't know I have it, and vice versa. I think it also is going to take more accountability and selflessness, right? So it's very inconvenient to quarantine. It's very inconvenient. My daughter had a fever. We took her to the pediatrician. We got her tested. We did everything the doctor said. It was inconvenient to wait until that final PCR came back negative and we realized that she just had a GI bug and she was fine. But I think it's the right thing to do. I need to not just give her Tylenol, send her to daycare and say, oh no, she's not had a fever. We need to kind of protect our fellow man. So it's kind of a tangent. And then also, and then I think ultimately, hopefully we need to get a vaccine and vaccinate, but we need a good vaccine. We need a safe vaccine. And we need people to take the vaccine. So that was kind of a lot of different tangents. Did it answer your question though? Yeah. So I would wear masks. And I think the other thing though is, it's, how do you make things as safe as possible? I don't know the answer with how do you date during COVID? I have no idea. I kind of don't know how you date right now anyways. I'm married and in my little bubble, but I don't know how do you date during COVID? I'm not sure the answer to that. I would avoid the 50-person parties. I hope they aren't going on right now at UTD. And it's sad. I'm sorry for you guys. I think this is sad. It's sad that my students couldn't have a white coat ceremony. It's sad. It's sad that they couldn't have a college graduation. That freshmen, you guys couldn't have a high school graduation or prom. It's sad. Obviously, death is sadder. We're trying to protect you and other people. But that's not to say what you're missing out on isn't profound.
We do have a question in the chat. How did you persevere through the difficult times of your medical school or residency years? And I know you've touched on this too in your presentation, but specifically during these times where burnout is real, what have you done to kind of mitigate that?
Yeah, I think that's such an important question. It's something I'm still working on. And I think each person is going to be a little different in what works for you. I do think right now, make a list of things that are important to you. And I think sometimes reflecting when you're in those burned out phases, are you still doing those things? If you enjoy jogging, are you still jogging? Why not? Are you still going to church if that's important to you? If not, should you? Is there a reason you stopped? Is there some way to get back into that? So for instance, what was it? It was this week. I think it was Tuesday. I just had a bad day. It was a rough day at work. I had some hard patient encounters. I was in a bad mood. It was a bad day. And so I didn't do work that night. I baked a cake and I took a bath. And to me, that was self-care. That's how I kind of dealt with the fact that I had a really crummy day. I think the other thing is communication is very important. So communicating with your loved ones, it can be very hard. Med school is straining for students, but it's also straining on the loved ones, on parents, on siblings, on spouses or significant others. And so I think trying to have an open communication of what you need and what they need. I would always, in residency, I would tell my husband, okay, I'm leaving in 30 minutes. And then he would joke, okay, I'll see you in 2 hours. And sure enough, I would come home in like 2 hours because I stopped by a patient room or something. So I think having that expectation, and, for him, if he told me I can't have you say 30 minutes if it's not 30 minutes, we knew what worked or didn't work. So I think trying to have that communication of what you need and what your family members need is important. Yeah. And then the other thing I think is very important is, and we touched on this earlier, I kind of praised your generation and my generation on doing better with mental health, not being afraid to ask for help. If your mood is low, if you're burned out, if you are depressed, finding a counselor, finding someone to talk to about these things. And if ever it does seem like it's too much, reaching out for help. Because unfortunately, with medicine, suicide rates are much higher than the general population, and it's devastating. And so I think not being afraid to ask for help or say when it's too much, because it's not a sign of weakness.
Definitely, absolutely. We are going to start wrapping up a little bit. It's getting close to 7:30. We do have one more question for you, Dr. Voit. This one's usually a fun question I like to ask. Do you have any book recommendations for pre-med students like us, either on the topics you've discussed in your slides here, or healthcare in general, or any topic that comes to interest? That'd be helpful.
I have a handful. So one, I loved Atul Gawande. So he wrote Better and Complications. Both of those I loved. I read them when I was a junior in undergrad at UTD. Thought they were great. When Breath Becomes Air. That's really sad. So read it where you're okay crying. I read it on a plane, was sobbing on the plane. That's it was written by a physician. Have people read When Breath Becomes Air? He's a physician. He was a neurosurgeon at Stanford, got lung cancer. And it was his memoir. He has like a master's in something literary from Stanford. So it was just beautifully written. When Breath Becomes Air. Being Mortals. I mean, it's kind of a classic, but a great one as well. And then I'm trying to think, oh my goodness. So those are a couple of my big ones, but those four were wonderful. And then what's the other one? There's one book I really enjoyed. It was either called Slow or Slow Medicine. I can't remember which one, but I liked that one as well.
Awesome. Well, thank you so much. We're going to be compiling all those book recommendations and sending it out to all of our members. We weren't able to get to all the questions tonight. We ran out of time here, but is there a way that we can compile them all and send it to you, Dr. Voit? Or
shoot me an email, Stephanie. The one thing is I'd say too, for the biggest tips for pre-med students, write everything down. Do what I say, not what I did. Write it down. You will forget. You think as a freshman and a sophomore, you'll remember it all. You won't. Write down what you do. Write down the number of hours you did. Write down the description. And that way, when you actually apply, your work's already done for you. But kind of compile your CV starting now. And look into shadowing. The med schools really do care about shadowing.
Absolutely. Got to get started early.
Yes.
Well, thank you so much, Dr. Voit. This was an amazing experience.
No, thank you so much. Feel free to email me, and thank you for dealing with my technology and my tangents, both of them.
No worries.
They were all very interesting, so not a problem at all.
Yeah. And thank you guys for what you're doing, like to keep your fellow colleagues and to keep everyone safe. It's an unusual time. It's certainly something we'll be talking about for decades to come.
And everyone's saying thank you in the chat too. So
no, thank you.
Lots of love.
And the last thing I will say too is thick skin. I think someone had asked a question about dealing with like difficult attendings. Just work on thick skin. It's something I'm working on. But keep in mind your priority is to yourself and to your patients and your loved ones. And, that helps.
Absolutely.
Thank you guys so much. I hope you have a wonderful rest of the semester. And Stephanie, thank you for the invitation.
Of course. Well, thank you again, Dr. Voigt.
Okay.
Thank
Bye,
you for
guys.
coming.
Thank you.
Bye. Bye, guys. We'll be here if you guys have any other questions, but feel free to sign in and take off. If not, otherwise.